Hi, everyone, and thank you so much for joining us for this Ask the Experts MSA Q&A session. A special thank you to everyone in our community who submitted their questions through MSA Connect. We're so grateful for you being a part of us creating this resource for our community, and we hope that in the future, as we do more of these sessions, you'll continue to engage with us in MSA Connect. Let us know what your questions are. I would definitely encourage those of you who maybe your specific question isn't answered in today's session, or maybe you have follow-up questions about it. MSA Connect is a great place to continue asking those questions, talking to each other about MSA. With that, I want to introduce our speakers for today. We are so grateful to be joined by Dr. Nadia Stefanova, who is a professor of translational neurodegeneration research at the Medical University of Innsbruck. She is going to be covering some of our more research-focused questions. And then we're also going to be joined by Dr. Paul Beach, who's a professor of neurology at Emory University. And both of these institutions are MSA Centers of Excellence, and we are so excited to hear from both of them as they kind of dive into some of your questions and talk about what we know. Before we jump in, I do just want to give a quick disclaimer that nothing in this session today is intended for the purpose of providing medical advice and should not serve as a substitute for talking to your own medical providers. All right, with that, we are going to start by having Dr. Beach join us to go through some of our questions that are more related to symptoms, treatments, and that kind of thing. So we're so excited to have him. Again, just a reminder that nothing in this session is for the purpose of providing specific medical advice, but we're going to jump into some questions.
Let's do it.
Awesome. Okay, so our first question is, could you kind of walk us through and describe what the final, few months or weeks look like for someone diagnosed with MSAP?
So this is a good question. And what I would say, as far as kind of the end of life for folks with MSA generally, is that depends on what was going on just prior to the end of life. By and large, one of the most common reasons for folks with MSA to pass away is related to a combination of disease progression, but also the things that MSA allows to happen more easily. This is similar to advanced Parkinson's disease. So folks with advanced MSA tend to have difficulty with swallowing. And so that can lead to folks developing aspiration pneumonias where things go down the wrong pipe. Sometimes folks may have lots of coughing and sputtering when they have issues with swallowing, but sometimes patients don't necessarily know that they have these issues. So you may have what we call silent aspiration, and that can predispose patients to developing a pneumonia. Patients can also get frequent urinary tract infections, and in someone who becomes very ill from these things, they can kind of become systemic and cause very severe illness and a number of issues that come along with that in a condition we call sepsis. And so a number of individuals may pass away from things like this. And that course can take potentially a week or more, depending on what else is going on. At the same time, and one thing that I tend to try to advocate for patients that I see is to have a very clear plan in mind about what you do and don't want done in certain scenarios related to end of life care. And so the final months to weeks can really depend on whether or not you have a plan in place. And so I highly recommend that everyone with, whether it's MSAP or MSAC or really any other neurodegenerative disease like Parkinson's disease, that they have a clear advance directive and a set plan in mind for if things go irretrievably wrong, then everyone knows and is on the same page about what people want done as far as advanced care and where that advanced care should take place. So folks who have that clear plan in mind, they may forego hospitalization in the setting of an illness and advanced MSA, and they may prefer to end their time at home, surrounded by family and loved ones. Oftentimes, this may take the form of hospice care as well, and that can take anywhere from days to potentially months. People can be in hospice care for, I believe, up to 6 months, depending on where you are. And so those final weeks and months can look very different from person to person. And, sometimes there are things that come about that no one can foresee. There is a known risk in MSA of sudden cardiac and respiratory arrest from stopping breathing if the disease impacts breathing centers of the brainstem. And this will tie into a question later, I think. And so we try to avoid that by making sure we know what goes on when people are breathing in their sleep and try to treat that appropriately. So that's why and neurologists will be pesky about having sleep studies done, for example. So I say all that to say that the final couple weeks and months, there isn't a very, very specific set of events that take place. But what I would advocate for is that folks have a general sense of what they want in a scenario where it looks like one's life is coming to an end, irrespective of whether or not they have MSA, but particularly in the case of multiple system atrophy.
Thank you so much. Another question that we got from a few people was kind of involving, different stages of progression in MSA and how to kind of tell, where they're at in that progression. And so, are there definitive stages of progression in MSA, and how can you kind of gauge where you're at within that progression?
Yeah, so this is also a great question. We get the same questions all the time in clinic about this. What stage am I? That kind of thing. And different physicians and different patients will want to look at it from different standpoints. I tend to think about it in terms of motor milestones. So, as most probably know, in multiple system atrophy, there's unfortunately a relatively rapid progression and accumulation of disability. And so, what do we mean by that? Predominantly, we're thinking about disability with respect to ambulation and the ability to walk about independently. So, within a couple years, 2 to 3 years, sometimes patients may start to require an ambulatory aid, such as like a cane. A couple years later, somewhere around 5 years, perhaps, although everyone's a little different, there's some wiggle room here, of course. Folks may require something like a walker for ambulatory assistance. And as walking becomes more and more challenging, and there are several reasons why this could be, it could be from blood pressure problems, it could be from Parkinsonism or ataxia, freezing of gait that can happen with Parkinsonism, or any combination therein. Folks may eventually lose the ability to walk, even safely walk, I should say, with the use of a walker. And so they may become more and more reliant on wheelchair. And that may happen somewhere around 7-ish years. And so a lot of us will think about motor milestones in terms of those three primary events. There are kind of more academic stages that are looked upon in MSA. So, for example, in one of the clinical rating scales that we utilize called the UMSARS, Unified MSA Rating Scale, there is a clinical global impression of impairment that is rated by the provider that's filling out the scale. But a lot of those things kind of think about similar issues, more in terms of one's ability to independently perform things around the house. Like, are you just a little slower? So that maybe a score of 1. Do you require a little assistance and you're a little slower? You get a score of 2, as opposed to somewhere at the further end where you can't necessarily do a lot of things independently, like hygiene activities or ambulate or do chores around the house, and you rely more fully on a caregiver or a heroic family member. So more like a stage 5 or 6. We have a similar thing in terms of Parkinson's disease called the Hoehn-Yahr scale that is very much related to ambulatory ability as well, but operationalizes it in terms of, is the right and the left side of the body impacted? So that would be a score of a 1 or a 2. Is balance beginning to be mildly affected? So more of a score of 3 and 4. Walker, wheelchair assistance necessary, more of a score of 5, and inability to walk at all, requiring a wheelchair for all mobility, maybe being in the bed, or a score of 6 there. So everyone's a little different in terms of how they like to relate things to patients and how they think of it themselves. But I'm partial to thinking about motor milestones because those tend to be kind of the biggest events in terms of MSA progression and the things that down the line we would hope to prevent or slow down with any potential disease modifying therapies.
Yeah, thank you for sharing that. I think that's really helpful perspective. Another question that we have is, are anxiety and insomnia a part of MSA? And If so, what do you typically kind of recommend that patients do for relief from those things?
Yes. So I like to think of this kind of in two ways. Anxiety and insomnia, unfortunately, tend to go together. And so a lot of anxious sleepers, people who have racing thoughts or just kind of ruminate on things, that can tie into insomnia. That can happen as part of the disease process in terms of what parts of the brain are impacted. But it can also happen as kind of a normal reaction to what one is going through in having this disease. So absolutely, this is part of what one may go through with MSA. In terms of how we go about trying to provide relief, so with respect to anxiety, so there are two not mutually exclusive paths, right? So one is trying to get help with a therapist. Two would be trying to get help as far as like a medication, and that could be prescribed by your treating neurologist or a psychiatrist. Depending on your prior history and what's been done in the past, a neurologist may or may not want to take on fully treating anxiety or depression in MSA. Similarly with insomnia, so there are a lot of things that one can do as far as general sleep hygiene, like turning off screens several hours before bed, things of that nature. But at a certain point, those things may not be successful. And so you may need to go see a sleep medicine specialist with respect to insomnia, because insomnia can happen for a number of different reasons. And it could be insomnia that impacts your ability to fall asleep. You could fall asleep easily, but then wake up later. And then it's a question, well, what's waking you up in the first place? And then what's causing the insomnia after that? So there are a lot of different ways to think about how to attack it in terms of really trying to find a root cause, treat that, and then see if that provides relief.
Awesome. Thank you. Next question is, how does the disease sort of manifest with MSA patients breathing and things like wheezing and coughing?
So this is a fantastic question. And it's unfortunately one that hasn't been asked enough by people like me and trying to learn more about this and how to treat it. So breathing can absolutely be impacted by MSA through a number of different ways. So in folks with Parkinsonian MSA, you can have rigidity, just like you get rigidity in the arms and the legs and the neck. You can have rigidity impact the muscles that help with breathing externally. So this could include the muscles in between the ribs that help you expand the lungs. And so if you're very stiff from that standpoint, that can cause shortness of breath. You can have difficulty in breathing in the context of orthostatic hypotension, surprisingly. This would typically only happen when you're up and walking, but you can have shortness of breath, specifically just from the context of a blood pressure fall with that condition. Coughing can absolutely happen in a setting of more advanced dysphagia or trouble swallowing. So folks may develop coughing fits just from inability to appropriately swallow one's own saliva, but especially when trying to eat or drink. Stridor is another condition that can happen and can be challenging, I think, for some folks to detect. Um, it's basically a very high pitched inward breath. Physicians tend to think about it actually more in the pediatric population in the context of certain pulmonary conditions that young infants may get, but it's a very sharp inward breath and can be associated with risk of difficulty breathing in one's sleep and developing what we call a central sleep apnea. So that's where the brain doesn't send the signal to breathe, as opposed to obstructive sleep apnea, which is where part of inside the larynx and pharynx kind of cuts off airway movement. So I've had a number of patients who have had some of these issues, and it honestly can be one of the more challenging things that patients may develop, particularly if it occurs at rest, which it can happen. And so I've relied on the thoughts and opinions of pulmonary colleagues to perform pulmonary function tests and make recommendations about how to treat breathing problems that folks have developed. There can sometimes be things that one can do at home to help with some of these things, like spirometry techniques that one can do in practice, similar to the things that one has to do in practice with other therapies that may be prescribed by a physical or occupational therapist or speech therapist. And so just like all the other things, that how you kind of treat something and approach it depends on what you think the root cause is. And so sometimes we have to get help from other colleagues that specialize in that issue. So in this case, breathing. But in general, I think kind of the breathing issues that patients can develop are a bit understudied, particularly in terms of how they impact quality of life and the best treatments for some of these things. But it can absolutely be a concern. When in doubt, talk to your provider about it, get the conversation started, and advocate for yourselves to see if this is something that can be intervened upon to make your life better.
And that's great. Thank you for explaining that. We had a few questions related to investigational drugs. And so we're just wondering if you could kind of explain what are investigational drugs and who has access to those.
Yeah, so I would interpret this question as potentially meaning one or perhaps both of two things. An investigational drug, kind of from the FDA, the Food and Drug Administration perspective, is any new pharmacological agent that is being looked at from the perspective of a clinical trial to help treat something. So in the case of MSA, this could be something, any medication that could be used to treat a symptom specific to MSA, right? So some of you may know of the current trial, the Cypress trial to treat symptomatic orthostatic hypotension in specifically MSA. That's an investigational drug. It's going through a phase 3 clinical trial to see if it can get approval to treat symptomatic OH in MSA. There are current potential disease modifying clinical trials that are ongoing right now, such as the Mascot trial, which is the current phase 3 that's going on. So that's an investigational drug. So people who get access to these are typically people who are in the trial, depending on what phase we're talking about here. So, right, there's phases 1 through 4. Phase 3 being kind of the big decision point to determine whether or not it's going to be prescribable. There is a movement amongst some patients and patient advocacy groups for various diseases, not just neurological ones, to try and get investigational drug access outside the scope of a clinical trial, however. And so I'm wondering if that's really the kind of the root for this question specifically. And theoretically, that is possible. There was actually an interesting article in Neurology Today, which is something that gets sent out through the American Academy of Neurology to people like me, that looked at this phenomenon and found that a lot of physicians are asking how to get patients into this, and a lot of drug companies are not interested in doing it. And there's actually an expanded access webpage through the FDA that kind of looks at this question en masse for really any kind of drug trial. But my understanding with this is that it can be very challenging to orchestrate. And there is a lot of back and forth that would have to take place between your provider, the company, and potentially the FDA. And so you can, in a sense, kind of understand why a company may be reticent to do this, because the whole point of a trial is to determine, first, is it safe? 2, does it work? And 3, does it really work? Is it still safe? And so if you have a drug, especially one that's not nearing the finish line, there may be potential risks that haven't been encountered. And so you're putting yourself potentially at risk by taking that investigational agent. There also may not be the infrastructure to administer the agent. So a lot of disease modifying trials are using IV medications, for example. And so the practicalities for getting that drug to whatever infusion center you would be going to, or at the center in the academic institution you may go to, can be very challenging. It's challenging even when it is an FDA approved medication. And so that is my answer to that question. It's a theoretical possibility more than anything else. And yeah, it can be very difficult to make these things happen.
Got it. Okay. Thank you. Our next question for you is, what are some proactive measures that can be taken to lessen the daily decline that you see in speech function? So, like speech kind of declining from morning to night.
So very good question. So a lot of motor symptoms are at their best in the morning and at their worst later in the day. And in contrast, autonomic symptoms may go the other way. For example, orthostatic hypotension tends to be worst first thing in the morning and tends to get a little better later in the day. So as far as speech goes, it may be no different from the motor changes that I mentioned earlier, where you may be at your best with speech and swallow in the morning, and it may get progressively worse through the day. And it can fluctuate even throughout the day. If you're very stressed, for example, your speech may suffer. And so one thing, particularly in folks who have Parkinsonian and MSA, that I'm keen to tell people to do is if you're on a medication like levodopa or another dopamine related agent to help with your movement, generally we want people to be at their best when they're eating or when they're having to make a lot of speech and do a lot of talking. So usually you would want to have your medication to help with that within a half hour to 60 minutes before eating. So you want to be at your best in that sense. And that may help with speech and swallow. I've had patients where that's the case, even though you don't get that robust response that you would expect to see in Parkinson's disease, right? That's characteristic of MSA to not see a robust response. You can still see a clinically meaningful one. And so ideally, someone like me would be working with a patient to really determine when we're trying these medications is even if we're not seeing a 30-40% improvement or greater on the clinical scales that we do, what does the medicine do specifically for you? And so we may say, we need you to pay attention. An hour after you take your medicine, what do you notice may be better? It can be something simple like speech, or even just doing things fine motor wise with respect to hygiene or clothing. So it's important to figure out what may get better with you. The other thing that can be helpful is if you've seen a speech therapist and you've done programs such as Loud or Speak Out, or you've done programs looking at how to improve swallowing function, that you should practice those things that the speech therapist does with you regularly, ideally every day. Just like you would want to exercise the body, you would also want to exercise the voice and the swallowing muscles to try and maintain that function. So that's how I would approach that problem.
Yeah, that's really helpful. Thank you. So we did have a patient, write in that they had received a diagnosis of both multiple system atrophy and Lewy body dementia. And so is it common to have that dual diagnosis, or does one of those diagnoses kind of replace the other one?
A very interesting question. So I would think about that in kind of one of two ways. So there's the highfalutin academic way that one could think about this, and there's the kind of more practical clinical way one could think about this. From a highfalutin academic standpoint, co-pathology is probably more the rule than the exception. So, for example, it is not uncommon for someone to have a clinical condition that looks like multiple system atrophy. And we may even do some of the basic biomarkers we have that show that what you have is consistent with that. But then if you go to neuropathology after passing away, you may have some Alzheimer's related changes in the brain. Now, the degree to which that's actually contributing to what you experience and what your physician sees is another question entirely. If it's a question of you've been given a clinical diagnosis of both MSA and Lewy body dementia, which could mean either Parkinson's disease dementia or dementia with Lewy bodies, that's a bit trickier thing. So I would wonder, one, is that a diagnosis given by the same provider to the same person, or is it a diagnosis that two separate providers have given that are conflicting with each other? Generally, with multiple system atrophy, you should not have pronounced cognitive decline. That's kind of been the rule, particularly for really specific diagnoses, that you should not have early and pronounced cognitive decline and or dementia. Cognitive decline is probably more common in MSA than we previously thought. And some patients do actually develop a dementia, though it tends to be late in the disease. Folks who develop it earlier probably have other things going on that predispose them to that. Like, so maybe they have very bad vascular disease and that's impacted the brain. And so you may have a vascular dementia on top of MSA, for example. So I would wonder, and if this is a case where people are getting conflicting diagnoses for two different people, and that can be something that happens, or I doubt it's probably the academic question that I kind of thought about at the beginning.
Got it. Thank you. Another question that we have for you is, is suddenly falling asleep during daily activities like sitting, eating, using the bathroom, that something that you commonly see in people with MSA? And if so, what might be causing those kinds of changes?
So this is a phenomenon that I would think of under the category of sleep attacks, which is kind of a subcategory of excessive daytime sleepiness. And generally, this is not something we think about as a common issue in MSA, but just to make sure I wasn't saying a bunch of nonsense, I did look this up, and there is a paper in JAMA Neurology that was published, I think, 13 years ago that looked at this question, compared MSA and Parkinson's disease, and found that about a quarter of individuals answered questionnaires that indicated they may have excessive daytime sleepiness. And so the question is why? In conditions like dementia with Lewy bodies, it is a hallmark of that disease that the changes that take place in the brain because of the disease cause sleepiness during the daytime. It can cause bouts of literally falling asleep while eating. In MSA, what the study I previously mentioned found is that there was a relationship between the presence of excessive daytime sleepiness and sleep-related issues that probably took place nocturnally when one is supposed to sleep. And so if you have sleep apnea and are getting terrible sleep as a result of that, you're going to have daytime sleepiness. You may even have sleep attacks. At the same time, if you're on a boatload of dopamine agents, particularly dopamine agonists, those are known to cause sleep attacks. And so even higher doses of levodopa could potentially do that in someone who's a little more advanced in the disease. It tends not to happen in MSA because people are often backed off of those medications, particularly if it seems like they're worsening things like orthostatic hypotension. So it's not that common, but it's probably more common than we think. And in MSA, it's probably a reflection of poor sleep, for example, from sleep apnea.
Got it. Thank you. Another question that we have for you is, can exercise, physical therapy, or diet, generally help to improve symptoms or slow progression of MSA? And then kind of to go along with that, is it normal for someone who maybe is exercising and is engaging in physical therapy to actually feel more stiff or have more freezing the next day?
That's a fantastic question. I'm glad someone asked this. So if I could make and have a prescription to write for every one of my patients for exercise, I would do it. So exercise is something that has been studied extensively in the Parkinson's disease literature. And it's the one intervention that we have, at least in PD, that has pretty strong evidence that it could slow potentially the progression of motor symptoms of the disease. And so these are typically high intensity bouts of cardiovascular exercise that are being done in some of these studies. But generally, something is better than nothing. In folks with MSA, we have to remember that gravity often is your enemy. And so particularly in folks who I know have orthostatic hypertension, I'm talking about regular, ideally daily exercise with a recumbent bike, a rowing machine, or if you have access to it, a swimming pool is fantastic. Now, the extent to which it could potentially slow progression and improve symptoms in MSA has not been extensively studied like it has been in Parkinson's. And part of that is because MSA is a much more rare disease. But my inclination is that there's no reason to think that it's not having a positive effect. Anything that's good for the body is good for the brain, is kind of how I put things to patients. And so particularly with orthostatic hypertension, what we don't want to have happen is you have deconditioning superimposed on that issue. And that just kind of snowballs everything. So it's a use it or lose it situation. And you got to use it to the extent that you can and find something that works for you. And, of course, talk to your provider about what is safe for you to do. But generally, stuff that is seeded is going to be safe and it's still going to be effective. As far as the second question about feeling worse, maybe the day after, that's another pretty fascinating thing. I'm not as familiar with the literature on this question. It may be in part that if you have a muscle that was, worked hard on one day, the soreness and things like that may cause some sort of feedback and things like that from a brain and spinal cord standpoint that makes you feel more stiff and slow. my suspicion is that in the long term, you would see kind of more of a net benefit. And give yourself some grace, right? So if you're starting out an exercise program as someone with MSA, you got to start low and go slow. Okay. We're not talking about wanting you to run an Ironman. We are talking about getting to the point where you find something that works for you that you can do ideally every day. But you got to start somewhere and you got to build up slowly.
Awesome. Thank you. And so I know we just talked about exercise and physical therapy. What about things like acupressure and acupuncture? Are those helpful in treating specifically balance issues and bladder issues?
I wasn't sure how I was going to answer this one. So I will never tell someone that they shouldn't try something that seems kind of safe on its face. Generally, I'm not the biggest proponent of acupressure and acupuncture as far as something that would have a direct physiological effect that could do anything. But there may be some aspects of placebo effect, that's plural, that's the placebo effects that may be beneficial. This actually happens in orthostatic hypotension, it turns out. So you can tell someone that they have been given an agent to raise blood pressure and that may impact their standing blood pressure. And so those effects can be pretty powerful, though they tend to be short-lived. So when it comes to balance and bladder, again, I would not say there's absolutely no way that this would not have a potentially beneficial effect for you, but I suspect it would be short-lived. That said, if you find it to be beneficial for you and it's not breaking the bank any more than anything else that you're trying from a medical standpoint, and you have a provider who is, licensed and is doing things safely, especially if it's involving, needle puncture, then you could try it and see how it goes for you.
Thank you for that perspective. Just a couple more questions for you. One of them being in situations where an MSA patient deals with both neurogenic orthostatic hypotension and hypertension, is one of those of more concern than the other? And at what point should that one kind of become the predominant focus of treatment?
I love this question. And it's kind of it's something that it rears its ugly head quite often in MSA and in Parkinson's with autonomic failure too. And how do we treat folks who have both of these things going on? Sometimes debilitating falls in blood pressure when they stand, and sometimes incredibly high blood pressures when they lay down. It's pretty common. About a third of individuals, or perhaps a bit more with MSA, will have both orthostatic hypotension and supine hypertension. So as far as the question of when does one become more of a concern, the way that I think about that is what is going on with the person in front of me and what has gone on in the past. So in terms of the person in front of me right now, are they incredibly symptomatic from their orthostatic hypotension? So that's part one. That means we absolutely need to do something, right, to treat it, even if it's going, really hard with fluids, salt compression, and things like that, without medicines to raise blood pressure directly. If it's someone who, based on my review of their chart or working together with a colleague, for example, in cardiology or in vascular neurology, if this is someone who has very significant vascular risk factors, they've got a history of heart attack, stroke, aortic aneurysm problems. I've seen many patients like this. It becomes a different calculus, and then you walk a much finer line. In some patients, you don't necessarily have all of those things, but you may still have incredibly high blood pressures that are concerning when people lay down. And at times, you could have so much lability during the daytime that even while seated, patients will have very high blood pressures. And it can become a big challenge in treating these. Generally, we don't chase blood pressures. And so in folks who are highly symptomatic from falls in blood pressure, we absolutely have to treat that. We go after treating symptoms and maintaining function. When it comes to the really high blood pressures, I tend to think about tiers of severity and in terms of supine hypertension. And I would often need to know when is this happening? How severe is it? For example, when folks are going to bed and going to sleep, because that's really when folks would be exposed to this the most, right? It's when laying down for many hours at a time. And so there are ways to take a look at this. The easiest way is to either have you or a caregiver, spouse, check a blood pressure at bedtime after laying down for something like 10, 15 minutes, and you get a blood pressure then, and perhaps you check it first thing in the morning before getting up out of bed. So you at least have two data points that would tell you where blood pressure started at the night and where's it going. If you tend to wake up at night and you don't get out of bed, you could check a blood pressure in the middle of the night too. Then you have three. There's also scenarios where you could send home an ambulatory blood pressure monitor that goes off at set intervals on its own, collect the data on its own, and then someone like me could look at that trend and make decisions. And so what you make the predominant focus, again, depends wholly on what's going on in front of you, what's going on in the past. If someone has asymptomatic, very mild orthostatic hypotension, but insane supine hypertension, I will probably go after the supine hypertension predominantly and more actively. But I tend to treat it only at night and use agents like medications or other approaches like raising the head of the bed that will lower blood pressure just at night. And then paradoxically, that might help with early morning low blood pressure. So there are kind of lots of little tricks of the trade that someone might employ, questions that are important to ask and figuring out which to target predominantly.
Thank you. Our last question for you is similar, also related to orthostatic hypotension, but how do clinicians approach treating orthostatic hypotension, particularly fainting episodes or even episodes that feel more like seizures, when treatments and medications typically used for that aren't working?
Yeah. So I see this quite commonly. So I kind of go back to first principles when treating neurogenic orthostatic hypertension. And the first, second, and third thing I ask, is this person on anything that I can get rid of that might be exacerbating the blood pressure problem? So are they on, for example, my most hated of medication, tamsulosin and its cousins, Flomax is the other name for it, to treat prostate issues? I always wonder, is it really a prostate problem or is it really the bladder issue inherent to MSA? So I like to take medications away. So medications like that, or at times folks may be on blood pressure lowering medications for other medical problems related to vascular health. So it's a conversation between me and the internist or the cardiologist about perhaps altering the therapy a little bit. So hearkening back to the last question, if someone's on a blood pressure lowering medication and they take it in the morning, well, can we move that to the bedtime? And can we make it one that's been trialed in the setting of supine hypertension and found to maybe have a benefit? So there's then maybe switching and moving medication regimens. And then is someone really optimizing the non-medication approaches to treat orthostatic hypotension, really hammering in the fluids, using fluid boluses during periods of symptoms, being very careful about what's being eaten and whether or not that's causing falls in blood pressure after meals, medications that we might use to help with movement that can exacerbate this as well. So really paying attention to that. And if all of those things are taken care of and we're using things like abdominal and thigh compression and things of that nature, if we still run into problems, well, then we think about the medicines then too. Sometimes medications like midodrine might be very effective for a time and then be much less effective. So perhaps they're not working as well at the level of the artery. So we may be time for a drug holiday with that. Oftentimes we have to combine medications and think about whether or not those are being optimized appropriately. So maxing out on a medicine before we add another one, but then adding another one to see if we get a synergistic effect. At the same time, occasionally we do have patients whose autonomic failure is just so bad that they may be on 3 medications that are optimized. They're getting plenty of fluid. They're using compression, and we just can't get a handle on it. And in those situations, we still do our best to try and treat factors that may be exacerbating things. But then it may be a matter of, okay, well, we're trying to not get up and stand quite as much just because of those things. And if it's the summertime, we may need to just wait until the fall or the winter for that exacerbating factor to kind of pass. So that's generally how I approach it, and making sure that people who are around you know what to do in the setting of a faint or a fall, or even if it's, something like fainting while you're sitting, because that can happen at times in really, really bad OH. So knowing safety in that regard, knowing to lay down the person, bring the legs up that tends to bring them out of the things much more quickly and things of that nature. And knowing your own symptoms is really important as well. So sometimes folks don't have symptoms until their blood pressure is extremely low. And so if you happen to be one of those people, when you get the warning sign, that's your indication to get yourself seated right away, and perhaps even lay down to avoid something like a fall and a catastrophic injury.
Awesome. Thank you so much. Well, that is the last question we have for you. In just a moment, we're going to transition over to some more research heavy questions, and Dr. Stefanova will be joining us to answer some of those. But Dr. Beach, we just want to say thank you so much for answering these questions for us today.
All right, glad to help out.
Thank you all again so much for being here. Now we are so excited to have Dr. Nadia Stefanova with us answering a few more questions that are more specifically related to research related to MSA. So, Nadia, thank you so much for being here.
It's my pleasure. Thank you for the invitation.
Of course. So, our first question for you today is what makes early diagnosis of MSA so challenging from a biological standpoint?
MSA is a challenging disease, and early diagnosis is probably the most challenging at this stage because we actually don't know what causes the disease, when does the disease start before the clinical presentation. So probably there are stages, and we can be on time with the therapy of multiple system atrophy. And what are the reasons for this difficulty? When we diagnose a patient, we already have the clinical presentation. So the patient comes to us already in an advanced, to a certain extent, advanced state. And the difficulty of exploring those earlier stages is because either fluid biomarkers or neuroimaging biomarkers, which will detect in a healthy, clinically healthy person, possibility that this person will develop multiple system atrophy. So this is an area of research which is extremely actively worked on nowadays. What we are doing also, we are using experimental models, either in vivo or in cell culture, to address questions related to those early stages of the disease. Fortunately, for now, we don't have any possibility to detect those stages in patients. The diagnosis is also very difficult because there are significant overlaps between the clinical presentation of MSA with other disorders like Parkinson's disease, cerebral ataxia, other autonomic dysfunction. So there are many, many things to work on and to actively research with the support of patients, because this is only possible when patients are actively involved in this process of looking for the early diagnosis, which will also enable early treatment of the disease.
Thank you so much for explaining that. Another sort of related question is, are there any indications right now that MSA could be caused by toxins or other environmental factors?
Yes, people have been trying for many years to detect the cause of MSA. There have been studies on toxins, environmental toxins, occupational toxins, and all those studies have given a little bit of indication that there is some participation of environmental factors in the initiation of the disease. But unfortunately, those studies have always been statistically weak, meaning that because of MSA being a rare disorder, it's more difficult to get a large group of patients involved in such research. And usually those research projects are retrospective, which means that maybe there are some missing values in the whole analysis, or some patients which are not exactly MSA, but because of misdiagnosis, they come into this group. So there are many different parameters which are considered weakness of those earlier environmental and toxin studies. For MSA, we don't know the cause, but most probably environmental toxins play some role. Maybe not only factor for the disease, but one of the factors that play a role.
Thank you. Yeah, that makes sense. Another question kind of related to the cause of MSA and research around that. Is there currently research being done on whether MSA might have a hereditary component? And if so, what does that research look like?
Yes, hereditary component is associated with genetic factors. So let's also explore it in MSA. Again, confronting the same problem that we have a rare disease with very few patients which can be introduced into clinical studies. But still, there are some reports which show that there can be genetic component. For instance, there are those studies from Japanese families that define a certain mutation in a certain gene linked to multiple system atrophy. But on the other hand, there are studies from European and US cohorts which cannot find the role of this particular gene. Then the genetic background that develops and how it is spread throughout the population. There are very few family cases of MSA, usually MSA and some other neurodegenerative disorder. As a total, it's very difficult to claim that MSA is a genetic disorder or has a prominent genetic component. What is that? Nowadays, those genomic Y association studies, meaning that geneticists are trying to find genes that may be associated with the risk for multiple system atrophy. And this is again limited because of the low number of cases, but still it can give some ideas about possible pathways of disease which are involved. And then what we can also do when those genetic risk factors are identified by the geneticists, hence those genetic factors in experimental systems, whether this is in vitro, in cell culture, in dish, or in an experimental animal model. This is modeling, but still the only way at this stage to answer some basic biological questions, what can be the link between this factor and the disease that we have at the end.
Another question that we received is about the mean and median life expectancies for MSA that we have right now that are based on the age of onset, age of diagnosis, symptoms. This person asks, are there any correlated predictions of lifespan based on quantifiable symptom metrics or the way that symptoms change over time? Essentially, is there a more accurate, quantifiable way to determine what a lifespan might look like?
Well, unfortunately, the human body is a biological system, so it doesn't follow strict mathematical rules. There are always multiple factors that may interfere with the final result. This is exactly the case with MSA. We have a multifactorial disease, which means that environmental factors, genetic factors, other factors which we don't know maybe yet, may play a role in this whole package that we have at the end with a single patient. And during the course of studying MSA, people have tried different symptoms, different duration of disease and onset of disease, try to relate it to BIBA. But at the end, it is really very difficult because of the multifactorial character of the disease. On the other hand, we should not forget that when we have a patient, this person does not have one single disease. Usually with age, people get multiple diseases. This also interferes with the prediction. And that's why it's absolutely impossible to be precise and say you have 53 days until this and that happens. That's really serious.
Got it. Thank you. Okay, our last question for you is a question that someone wrote in about their wife who was diagnosed with MSA had an MRI showing volume loss in the cerebellum and the brainstem, which they expected, but also showed volume loss in other parts of the brain. And so this person is wondering if other parts of the brain are typically affected in MSA or in the later stages of MSA.
Yes, it is normal that in addition to what you expect to have in a imaging finding, you also see something different. Depending on the region, it can be associated with this patient has additional neurodegenerative component, not only MSA, but something related to dementia or some other neurodegenerative disorder, which will cause unspecific imaging characteristics. And this is exactly coming to show you how difficult it is to put a very strict limitation to a diagnosis, because you don't always have a pure MSA picture and you can have additional factors playing a role.
Thank you very much. That was the last question we had for you. But again, thank you so much for answering these questions for us. We're so grateful.
Thank you, Ella.